ourselves about the strategic objectives of the Trust. I don't know if someone can move the slide on, thank you. So, and this is really held in good sway over the last 4 months, really, because our objectives throughout the COVID response have remained these ones on this slide. So valuing our people, making sure we deliver high quality and safe services, making sure we really work with our partners across the STP and in the community. And my goodness, has that never been more important ever before over the last few months. And then making sure we provide services in a sustainable way. And really that is where we are heading into as we come into the recovery and the third planning phase of the pandemic response. So it's really, really important to keep these objectives in our mind as we go through the next hour, but just also think about how we've maintained those after over the last 3 or 4 months. So that's all I wanted to say by way of introduction. And Richard, who's our first speaker?
So I'm just doing a quick update on People First, and then we're straight into the speakers. So,
right, okay, so over to you, Richard. Thank you.
So thank you very much, Sarah. Great introduction. Just a quick reminder of what we're trying to achieve and what's at the core of People First. And some of you will have encountered some of this already, but really at the core are 3 really important pillars. A proper respect for staff in terms of all our staff are the people that do the work, they know the work best, and the people that ought to be can help us improve. Making sure that we never lose sight of the patient and the person we're caring for in our improvement topics, and allowing teams to drive improvements and make improvements happen easily. And one thing that's come across very strongly is when we've worked with teams is there's lots and lots and lots of ideas out there. So many. The more we can help you with those ideas and bring them to practice, the stronger this trust is going to be. So next slide. I think we just got a slight lag on the line while the slides switch. I think it takes a bit longer via the cloud. Sorry, thank you. So just when we work with teams, we try and achieve 5 things in terms of how we work with teams. So making sure that the purpose is aligned to our trust objectives, which Sarah so carefully set out for us, and that there's a real clear link between what teams are working on and patient impact and effectiveness. That teams are able to do PDSA, that they're really clear that actually they've got metrics that show how they're doing, which also align, and that we enable teams to have quite straightforward huddles. And just a headline for one thing coming very soon is our team healthometer, which will help teams reflect on how well the teams are actually doing, their openness and their psychological safety. But we'll talk about more at the next report out. So I'd just, without further ado, because I don't like to talk much in these, is just hand over to the first of our presenters, which is Kerry Killeen, who's going to talk about the work they're doing in CT inpatient flow.
Hi all. So this project that we've been working on in imaging around CT is aimed at improving patient readiness on the wards, which is to ultimately increase the throughput of the inpatient CT scanners. This will mean for patients that on completion of this project, there will hopefully be a reduced wait for inpatient CT scans, some of these which are discharge dependent. So when we started out, we did an initial scoping process of the project and found the following data, which was achieved by observing 1 team of porters for a day serving 1 particular inpatient scanner, which was out of 11 transfers, 6 of these were unsuccessful, which is a failure rate of about 54%. And then the reasons for these no scans and why they were unsuccessful was 2 patients refused, 1 was on dialysis, 1 was unsuitable, and 1 had been discharged. And this information was not available to the CT coordinator or the CT staff at the time of porter's dispatch. For successful transfers, the average on-ward delay was about 15 minutes, which brought the entire patient transfer from porter dispatch to porter return of the patient to approximately 45 minutes per patient. Also, key information on the patients collected was unavailable. These aspects of this information were being whether their cannula was appropriate or usable, whether they were a bed or chair transfer, if they were on oxygen, did they need an escort, or were they barriered. Another powerful piece of data which we collected was that on average, the CT coordinator was needing to call the ward approximately 2 to 3 times to schedule a patient for a scan, and that on average, the length of call was approximately 3 minutes. And this was simply due to the amount of time that was needed to gather the information on the ward side. So when narrowing the wider issue of readiness down, it became clear that the main avenue for improvement was to increase the visual representation on the ward of the information that needed to be relayed specifically to the CT coordinator in order for the particular scan to take place. So to address this issue, in a simple way, a grid was completed dealing all the key handover information that the CT coordinator would need to dispatch a porter for the patients effectively, and that's on the slides at the moment. And it was intended that this would be filled out at the time of the CT scan request or at the morning whiteboard and then placed by the phone, so that when the CT coordinator called for the patient, the information could be relayed by anyone who answers the phone, and the information could be relayed promptly to the coordinator. In the initial stages, it was delivered to 5 wards to act as a small trial group who had been identified as particularly high utilisers of CT for that day. And over a week, we then rolled it out to 10. After the first day of utilisation, it became clear that the grid was working well and that the CT coordinator could achieve the data collection in one phone call, which is detailed on the next slide, which lasted approximately 20 seconds. So that's quite a significant improvement. This project is now run for a period of 6 weeks, and it's produced the following data in a week's data capture at the 6th week, and that was by asking porters to collect data around their transfers for a week, detailing information on every patient they collected. In the initial stages, there appeared to be no difference in the successful collection rates between wards with and without the form, both measured at an approximately 83% successful collection rate. However, the wards with the form had a marginally less on-ward delay. 63% of the porters experienced no delay on collection with the form, and those without, only 36% of porters experienced no on-ward delay, and that's shown quite nicely in the graph that's on the screen at the moment. So that means that the form had accounted for an approximately 25% reduction in on-ward delays for portering collections for CT. So that was quite an improvement to see. So the next steps for this project are to look at improving that on-ward delay time further, which in turn will impact the successful collection rate. As of today, the next stage is we've implemented a shared CT coordinator email, which is going to deliver an estimated 24-hour notice period for inpatient CT scans on 3 targeted wards as a trial group. This will detail not only the name of the patient intended for the collection, but also the colour of the cannula that the patient is going to require for the examination. Partnering in this phase of the project is also a poster, which has been delivered to these 3 wards, detailing which scan requires which colour cannula. As on data collection that the porters collected as well, approximately only 83% of cannulas are suitable or usable for the CT scans, which in turn delays the CT scan and ultimately the diagnostic report for the patient. So by running this aspect of the project, we're hoping that we're going to be able to encapsulate fully the 3 main aspects of ward readiness, which are successful collection for patients, a usable, appropriately placed cannula, and no on-ward delay for portering collection. Obviously, throughout the phase of the project, I've been using the CATA method that the people first approach is quite pioneering with. I'm finding it's been really useful in my first experience of actually using the CATA method. It triggers very clearly defined gateways and targets within the wider project, which is really pivotal in driving its success. It's also a simple to use format, which has made it accessible to the wider team involved in the project. And I've also found that having regular coaching sessions has also allowed me to ensure that my next steps are focused on my prior learning and remain in scope, which I think has been really important in this project. There's been many aspects that I've looked at where it could have gone off on tangents, and by making sure that I'm keeping within the PDSAs and the coaching sessions, it's kept it focused and really quite hard hitting. So yeah, that's from my aspect of it.
Thank you, Kerry. Can I just say thank you very much. Brilliant update, and I've probably never heard such a fluent description of data through an update, which is absolutely amazing. So well done.
Thank you very much.
I've got a couple, maybe a question, but you've clearly outlined that you've used the Kata storyboard and had coaching, but
Yep.
how did that, you taking that approach, land with the imaging teams and the porters?
Yeah, so it's landed really well. Everybody's been incredibly helpful, and the porters have also been really useful in their data collection as well. We've been trying to engage with them as much as we can throughout the process, because I think by keeping them engaged, you're going to get the highest quality data. So I think that's been a really important aspect of it.
So, Carrie, thank you very much. I'm probably not going to ask you any more questions. There might some type up, but I'd also just like to commend you in having some exemplary data over time on that final slide. So I think we're now, thank you very much. So I think we're now moving swiftly on to Erin. Welcome, Erin.
Hello, hi everyone. Hi, my name's Erin. I'm the doctor's assistant for the colorectal team. We've been doing this improvement work. It started as a result of the 60-minute discharge guidance from the Department of Health in response to COVID. I don't know if you can see the first slide there yet. The problem that we've been trying to solve is that patients often wait a long time for drugs and to take home medications after they're surgically fit to leave the hospital. Unfortunately, sometimes this can take 6 to 7 hours to resolve, which is very frustrating for the patients. This delay on discharges obviously has a knock-on effect to the ward. It causes problems for the hospital, such as surgeries get cancelled, crowding in the ED, people are often left waiting in recovery for like a level 1 bed. All in all, as you can see, we've reviewed 25 patients across the 2 wards and found that most of the delays to discharge were a result of waiting for the TTAs to be ready. And before this change, the average discharge time across Walthamstow House was about 4:30, which you can see there. If I could have a second slide, please, that would be lovely. Thank you. We set a target of around 50% of patients should have their discharge summaries completed before 10 a.m. on the day before discharge, as this will allow the TTAs to be completed sooner. What we actually did was we started with the ward round process and trying to identify patients to be discharged the next day to prepare the TTAs, and to try and complete simple TTAs on the ward round by having people break off and updating them on the system as we're actually actively doing ward round. The result of that is that we had 2 days where we achieved the target for 100% of patients. Some days obviously do vary. We are managing this for between 30 to 40% of patients, which is up from 20%. The average discharge time for patients is coming down and has improved by approximately 90 minutes so far. The average time to complete the discharge summaries is also coming down gradually. And the next steps that we are going to carry on with is we're planning on, well, it's actually started, refurbishing the 2 wards, the doctors' rooms, where we've gutted them and put in extra computers for the doctors that also fits in with the social distancing. So there's enough room and enough IT equipment. We've also got some IT equipment extras on the ward rounds to enable people to be able to access the systems to complete these TTAs. We're going to be reviewing the 3:30 afternoon meeting process to identify patients who need discharge tasks the following day, to maybe see if we can get bloods on the system if someone's going home, so that we can get those done either the evening before or the morning, so that when they come in, if those bloods are on the system and they're done, it's just a case of doing a TTA and that person can go home in the straightforward patients, not the complicated patients. We're going to be reviewing the use of CPL on the ward round, where we can be electronically updating patient information. Things like Sierra have been amazing so far. And that's where we're at the moment. So thank you very much.
So Erin, can I just say thank you very much for coming on and doing the update. It's very, very kind of you, and some brilliant work. I've just got a couple of questions before maybe we look at what's going on in the chat. What are you clear what behaviours changed to allow you to discharge earlier? So it's great you've got the data, it shows it's happened, but what's actually practically changed to make it earlier?
Sorry, can you just repeat that? It broke up slightly.
I do apologise. So
no, that's fine, don't worry.
What's it's great that you've got the data and you're clear there's a change, but what's practically changed in terms of making it happen?
So it's just, we've got such a large number of surgeons. It's such a big team, as we have a large number of junior doctors as well. So it's just one of the biggest things and challenges I feel was getting everybody on the same page to go, right, this is what we'd like to do. This is how we're going to do it. But obviously we need everybody to be actively on the same page doing this, and actually getting it together. So, and we've got like a little system going on now, which is working really well. And the junior doctors have been absolutely fantastic. I'm just having a look at a couple of the questions there that are coming up with regards to, have you found the pharmacist screening at ward? Yeah, so that has been a huge help with the pharmacists actually coming up to the ward to screen the patients on the ward. It has made life a lot easier. It's a lot more efficient because there's somebody actually there on hand. So it has been really interesting. Sierra has also been an amazing thing. It's got everything on there that we need. So we have a discharge sort of discharge coordinator that's actively on Walthamstow House. She updates things regularly on Sierra. She also does her huddle every day, which helps with TTAs and things, and then obviously we can access and update that system as we go around when completing sort of, you know, sorting out the TTAs. They can get all the information they need off that system. So it's been fantastic, and everybody's really positive, and it's almost given everybody a bit of a boost to go, do you know what, actually we can do this, and we've got all the tools now to implement it. So it's just a case of trying to sort of up the numbers really.
So well done, Erin. And I just want to try and field Paul McCardle's question. I apologize if I'm glancing through the questions.
Thank you.
But I think his question is, how do you optimize the behaviours? And I think he's talking around the way we do the ward round, the engagement of the team. And have you got any particular barriers?
Some of the simple barriers can be each consultant likes to do their ward round their own way. And they work at different speeds, which obviously makes it difficult. Some of the other difficulties that we face are sometimes we have a huge number of junior doctors where there's a good split, because we tend to split ward round. We have a PA as well as junior doctors, and then myself, the DA. So myself and the PA tend to split. But if there's not many junior doctors on the floor that day, it can make life difficult. Whereas Monday, for example, we had one junior doctor, one with a registrar and one with the consultant, a PA and a DA. So that is a more difficult day if we've got a high patient number. But it's those things that we're kind of learning on the ground as we're going along and overcoming them and thinking, right, okay, this happened today. How can we better this? How can we improve this? And it's just having regular conversations.
So thank you, Erin. I'm going to hold the question. There's a few more compliments coming your way on the chat as well. So really well done. Please keep up the good work. I mean, it's really tangible. This has a direct effect on patients and hopefully how the team feel. So really well done. So I'm going to move across to Vicky, who should be waiting in the wings to talk about MRI.
Good afternoon. So in MRI, we found that when we call for patients to attend for their scans from the wards, there are numerous reasons why they're not ready. So cannulas, being able to answer their safety questionnaires, they haven't been kept ill by mouth for procedures. This in turn obviously causes delays for the patient, delays in receiving the diagnostic test and diagnosis, and causes downtime in our scanners. And therefore, at the moment, being very busy, we could try and need to get that capacity back. Extra work is also caused if safety issues aren't flagged early enough in the referral, as obviously the safety in MRI is vital. If it's not followed, actually can be quite catastrophic. So during the week, we collected data on inpatient readiness issues. It was identified that 4 patients a day, so approximately 20%, had issues relating to readiness. These communication issues caused delays to patient flow. The MRI coordinator is responsible for allocating the scan slots and performing all of the safety investigations pre-coming to the department. So we trialled walking wards daily rather than calling them, which we know is problematic because people can't answer the phone or it's during handover, so not always available. So the aim was to speak to the patient's staff and to complete the safety questionnaires to assess the patients for mobility and any issues, and to improve the communication with all the teams involved. And trialling this did help to reduce the communication issues to just one patient. During the time, the patients were really receptive, as they felt they got to speak to somebody who had knowledge of the procedure and what was going to happen. And if they had any questions or concerns, they were able to ask us, and we were able to answer and put their mind at rest. It helped to highlight incorrect referrals again, so mobility and safety issues that may not have come through on the referral. The ward staff feedback was positive at the time, and it was thought that the communication had been improved and information required for the process to proceed smoothly kind of allowed us to talk to the wards as well and let them know why we ask all these questions. So we're continuing to try the process daily. However, activity recently has increased dramatically, and releasing the coordinator to perform this task consistently has been a challenge. So what we'd like to do is to test the ward walk as to whether the process can be performed by an imaging care assistant, as this would allow the coordinator to remain in the department to fulfil the other aspects of the role, get patients through in a more timely manner, and it might work better. And we think the ICA would be able to identify any issues and liaise with the coordinator at an earlier opportunity than maybe if we didn't get a chance to speak to them and then they came down and weren't ready for the scan for some reason.
So Vicky, that's a really great update. So thank you very much. And I could see you from the sound of it, you're wrestling with other barriers as well at the moment. What was it like to use? I think you were working with a coach on the Kata storyboard. What was it like to use that? How did it feel?
As I say, we've been trying to collect the data and everything, and Ryan has been quite involved, but everything's sort of a bit up in the air at the moment because obviously we're not used to having this demand for MR at the moment. We think it's gone up to pre-COVID levels, so it's trying to capture everything and trying to get it to work. I think the data is showing that what we are doing is working, but we'd like more time to trial it and liaise with Ryan for it.
Thank you, Vicky. I'm gonna. There might be some questions pop up. Wish you best of luck in facing into those barriers, and I can see already it's making impact on MRI flow. So we maybe get another update sometime on how you're facing into those barriers. But really well done.
Thank you.
So I think we're now going to go to, and I'll just do a quick introduction. So this is Craig is going to talk to you about some work which was started some time ago, but I think he's going to talk to us about how he's continuing the work and the progress it's making on his stroke huddle and length of stay. So over to Craig.
Hi, can everyone hear me? Okay, so our journey with the Quality Academy started back in October. We started looking at kind of what our purpose was as a team, what our aim was to the service user, the patients. As you can see, our purpose statement on the slide, if it's not quite come up yet. So if I'll talk through it, it basically is to provide a seamless stroke service that supports, enables and empowers patients and their families on their rehab journey to achieve the best possible quality of life. Our first test of change, I did a report out a few months back where we looked at the information sharing within the MDT. We did a process mapping exercise which showed there was a lot of duplication, and what we wanted to look at is how we could refine that and to improve the information that the staff and the team had, but also the information that the patient and the relatives had. We looked at some of the results and we found that the information transfer between all of those stakeholders improved, and the planning for that patient also improved as part of it. So that was kind of like where we started from, but it was also part of a much bigger picture. We put in a successful business case which resulted in the enhancement of our therapy resource. Prior to that, stroke therapy had been both limited at the weekend and in the amounts that we could provide to our patients. We were failing on some of our national targets for stroke audits, which is so certain metrics of stroke are measured nationally on a live audit system. And also limited availability of our rehab pathways, both inpatient and community, also limited how quickly we could get that input for our patients. So as kind of like the bigger test, the increase in our therapy service led to a 7-day therapy provision. And what that's allowed us to do is to assess our patients much more swiftly. And the graph that you can see on the first slide shows that the area of the graph before the yellow dashed line 1 was before we had a 7-day service. Line 1 is when 2 of our professions started 7-day, 2 and 3 are when the subsequent professions then started their 7-day service. And as you can see, as the left-hand side of the graph, our compliance with early assessments of our patients was for some of our metrics down in the 40 percentile range. And now we're approaching more the 70 to 90 percentile range. And on occasion have actually hit 100% for all metrics, which is above the national average. If you could turn the slide, please. So we've applied the people first approach, where we've employed a huddle strategy. We've instigated several different tests of change within that. The initial test of change that we looked at with the plans and the communication within the MDT has evolved quite substantially through our PDSA approach. And we now evolved it into each patient having an individualized therapy folder, which, the slide there, which includes things such as independent exercise programs, goal setting for the patient, any kind of other advice, information that the patient, relatives or staff might need to help enhance the patient's experience and to essentially expedite their recovery. And that has been part of one of our tests of change. We've also had several others go along sequentially and sometimes parallel to that. So along with those tests of change and with the enhancement of our therapy service to a 7-day service, we've seen a significant reduction in the length of stay of our stroke patients. And as you can see on the slide now, the graph shows so that the blue line is the average length of stay week by week. Again, those dashed yellow lines being the points at which we started 7-day working for each of the professions within the team. And then the black, less spiky line is the 7-week moving average, just to kind of show more of a trend line as to where we're heading. For the bed model that we planned the whole therapy uplift for, which was 22 stroke beds, we operate on allowing 20 beds because we always need to have 2 emergency stroke beds for urgent admissions overnight and throughout the day, particularly for out-of-area thrombectomies and thrombolysis. But what that means is that for any given time, we're aiming for an average length of stay of 8.75 days per patient to maintain break even for that size bed model. As you can see, after we implemented the 7-day working, the average length of stay has dipped below the green line and has maintained there indefinitely so far. Also keen to point out that that was also pre-COVID and lockdown. So we know that the changes there were not due to changes in the services in response to the COVID situation. Okay, I think.
apologise. I was talking to the audience there and I was on mute, so I do apologise to everybody. I was just saying well done to Craig. Really impressive to see change being sustained from work that's been brought back earlier, still using the huddle format. I think one of the things you described, Craig, was a personal folder on their therapy plans, which I know has been a boon to the ward. But there's an important question from Paul McCardle there on how do you embed this change in the long term, and are there any risks to losing the gains already made?
Okay, yeah, thank you for the question, Paul. So what we've tried to use is essentially built in the monitoring of this within our huddle process. So as our data is weekly, within on a Wednesday each week, we go through the actual data and show what we're actually achieving on a week by week basis. That's broken down within each therapy team within the wider team to show if there's any particular areas where we're then not achieving what we want to do. And other things, we're monitoring other potential weaknesses. So within the huddle, it's built into our format that we check if the processes are all running smoothly. Are we seeing the patients in an adequate time frame? Are we aware of any outliers, which has particularly been an issue we've found during this period because of the COVID screening methods and patients being outlined to other wards, and having eyes on those patients and being able to support them and the outlying teams has been an issue. And we have noticed that the length of stay of those patients had started to increase. And we built in a change to our approach using the huddle format, and again, a very brief PDSA quick-fire change to help bring that back around and maintain that reduced length of stay.
So thank you, Craig. I'd also like to pass another couple of compliments your way, if you don't mind. I think Donna is using Donna is using you as a bit of an exemplar, and people are coming to look at your huddle and how you're using data. And I just want to shout out again for the visual stuff you've done on therapy plans on the ward. I think it's really impressive. So big thank you to the therapy teams and the team on the ward. Really well done. So we're going to move on. And the next presentation, Laura should be able to control the slides well, because she's going to give the presentation herself. So is on ultrasound and the tests that we conducted with ultrasound last week.
Hi everyone, my name is Laura Speed. I'm SI lead in the Quality Academy, and I've been supporting Chi Lam, who's the superintendent radiographer, and she unfortunately isn't available. She's clinical this afternoon, so I'm going to give you some headlines on the test of change we'll be doing in ultrasound outpatients, and then hopefully Chi will be available at the next report out to give you the full update. So ultrasound outpatient. So the aim was to improve patient experience and flow through the department. In COVID conditions, they were having 7 scans per session, and the sonographer would be on their own in the room. This means that they would be doing the cleaning and prep between each patient, as well as having to report the scan. It also could provide difficulties. So if a patient required chaperoning, that would mean they'd have to find a chaperone for that patient's scan. So the test proposed was to have an assistant, either an imaging care assistant or a healthcare assistant, in each room with the sonographer. And the aim was to book 10 scans per session, whilst maintaining a safe waiting area in the ultrasound department. So with the current COVID guidelines, we would have to keep the social distancing still in place. So that test took place on the 22nd of July for the full week, and each session had an ICA and HCA in with the sonographer. Throughout that week, we collected patient feedback. I'll just move on to the next slide. Hopefully it moves on quickly to you. Sorry, it might not be moving. Okay. So throughout the week, we collected patient feedback, we monitored the waiting area, and we collected information on the patient's time before the scan and in the scan, and we collected staff feedback through the week. So the patient feedback was absolutely fantastic. We had 78 responses across the week, and And for the question, I felt safe during my scan, we had 77 respond with a strongly agree, and what the one remaining was I agree. I've just been told the slide's not changing, although I have changed it on my screen, so bear with me. Hopefully that will update soon. I think, has it just changed now? No. Oh. Right, does that work now? Sorry, it's because I'm changing the slides at the same time. Right, so the patient feedback across the week was absolutely fantastic. So we had 78 responses, and a really important question was whether people felt safe during the scan. And we had 77 respond saying they strongly agreed they felt safe, and one person was an agree. So really fantastic feedback. We monitored the waiting area really closely throughout the week. It was managed well. This also reflected in the patient feedback, with feedback saying that they felt there was adequate seating in the waiting area. Throughout the week, we got really good engagement with the staff to have feedback. There was what went well was an even better ifs up on the wall, so they had the chance to feedback us throughout the day. And we also had team huddles, which gave them the opportunity to talk to how the week was going. The staff also helped us collect data. So they collected when the patient was arriving, the time they were going into the scan, and when they were leaving. So across the week, in total, there were 20 sessions that we were hoping to impact upon, so have an increase of scans in those sessions. So we impacted on those sessions because we did have the ICA in the room, but with regards to increasing the number of patients or number of scans through those sessions, we affected 14. And we saw an extra 25 patients across the week. So that equates to 3.5 extra sessions a week, which is a really, really positive result. So our next steps are to be reviewing the data that we've collected for the test week, and also to review the same information for a normal week in COVID-19 conditions. And then we will be looking at what our next steps will be for the project, and Chi Lam will hopefully be able to give you an update at the next report out on the next steps.
So thank you, Laura. A great update. I know you're not trying to steal all of Chi's thunder. I just wanted to just ask the question, how did the huddling during the week and getting the teams to collect data go with the staff? How was that received?
Really well. So every day there was information updated on the sheets, which really helps us know the impact it has for the staff and the running sessions, and also the impact it has on the patients. For example, some of the staff feedback that it's much easier to help elderly and frail patients. So we know that if we've got 2 people supporting an elderly or frail patient, then that's a real benefit for the patient and for the staff in that experience. So and just having the huddle, there was a good representation. We had people in the corridor, social distance, and we also had people on Teams as well. So it was nice to be able to do that interactive huddle and it to work really well.
So thank you, Laura. I'll just reflect on another couple of things. I know there's some thanks to do here. A brilliant test by the superintendent sonographer, Chi Lam, who I know has driven this team and the process here, so well done. But also to David Edwards, probably on the call somewhere, for supporting the test and resourcing the rooms with ICAs for the week. I think all the patient feedback was cognizant that every room had a chaperone in and people helping them. And it's really interesting that the levels were achieved better than pre-COVID productivity through those rooms, which is fantastic. So just well done to everybody involved. And I know David, Chi and the team will be building on the results of that week. So brilliant. I'm just trying to see if there's any questions there related to that one. There's lots of compliments. So that's good. That's fantastic. So the next one is less of a it's more of a highlight of stuff that's coming your way. So Steph Morgan, who works in the Quality Academy, is working upon wards, and she's going to explain some of the stuff that's coming towards standard work. So over to you, Steph.
Afternoon, everybody. I hope you can all hear me okay. So yeah, our focus at the moment has been around the sharing of information and the way in which we work very differently across wards. With the dynamic teams that we have that are often asked to work in different areas that they wouldn't normally work in, it can be quite tricky for them to kind of get on board and understand how the different teams work and different ward areas work. So by looking to develop standard work, it hopefully will help with the flexibility of our staff, and help them be able to do their job in the best way possible. So what we identified initially through some respiratory improvement huddle work that we did up on Hexworthy and Honey was that there is often gaps between information held by different members of the MDT. Multiple documents, and nurses have one handover, doctors have another handover document, physios, OTs, etc. All have their own ways of recording their information relating to the patient. And as a patient, this would lead to quite inconsistent messages, inconsistent information, and also be quite unsettling for them, and equally quite frustrating for the team, not being able to act on the most up-to-date information all the time. So there was a system that was existing within the trust called consultant patient lists, which had been developed by the IT teams. It was predominantly designed for use by doctors. Doctors weren't really updating it consistently, so there was lots of missing information, and something the respiratory team wanted to do was pull everything together and have that input. So what we have been able to do by building our working relationship with the IT team, particularly the software development team, is to take that consultant patient list and make it into a clinician patient list, which functions through CARE, which obviously you've heard about a couple of times so far today. It really shifts the focus, so it's a lot more focused on goals and not issues. It's a live MDT document updated throughout the day at the point of patient care by the different members of the MDT. It also links in with other programs that we have, so it can link with our e-discharge, and information can be pulled across, and the information follows the patient across the hospital, leading to less errors in terms of data input and information input, which has been really, really helpful. And the teams that we're using, it's currently live on 6 wards. The teams are using it really effectively, particularly on Meldon, where the whole MDT is using that document as their driver for their discussion in their MDT ward meetings. This then led on to us looking at how we can improve our information sharing across the digital MDT. Next slide, please, Laura. So we've got a massive amount of information available to us as clinicians on a ward, a lot of which doesn't get utilised. So it's moving away from what we've known before in quite a disjointed conversation, relying on lots of checking back. Oh, I'll just come back and get that information for you, or I'm not quite sure if that referral's gone in, I'll have to go and check, leading to an often extended delay, waiting for different things to happen for the patient. So by pulling all these things together for the teams, it allows them to update lots of information concurrently. So the model we're working on with Meldon at the moment, and shortly Hexworthy, is that there is no whiteboards anymore. They're using standard process, standard ways of working to update and use that information throughout their MDT meeting. And it involves all of the MDT. So Wall Clerk, for example, will be updating Salis. The conversation focus was a lot more around information available, such as allergies. You're able to look at the discharge status, estimated discharge dates, and all of that can be updated as the discussion happens. And with the introduction of SNAP through CARE, so that's a medical photography app, you've got access to that also, as well as using the information on CPL to drive that discussion. Another big game changer has been allowing us to see GP Connect. So we've got access to a view-only GP record, which is available 24 hours a day. So that really helps reduce delays in obtaining current patient information, such as critical meds, whether they're up to date on their vaccinations in terms of influenza, along with various other things. So as you can see from that slide, lots of information available and really usable and accessible for the teams on the wards. Next slide, please, Laura. So the ultimate goal is to create a cohesive MDT format, which does rely on standard work. Whilst it's great to have lots of technology that we can use and pull that information all the time, we really do need to focus on the key thing for our bread and butter, which is the patient. So by using the information available, we can focus on 4 main things really. And to put it in a patient context, why am I here? Why am I here as a patient? What have I come in with? What do you need to do to me? What needs to happen during my stay here? So what investigations will I need? What treatments will I need to have initiated, and really keeping the patient up to date on those as well. The third question that it focuses on is, when will I go home? So giving that patient a realistic expectation of what is going to happen to them while they're here under our care. And also starting the question of, what do we need to get the patient home earlier on in their journey? So we're focusing on discharge from the point of admission, but really being more coordinated in our approach to that. And by having that traceability and the sort of a historic view of the patient, as well as what's going on currently, whilst it's being updated live by the NDT, really aids that. And the feedback so far from the ward teams has been fantastic, and there has been an awful lot of interest in, when am I getting this on my ward and for my team. So it is really a really good progressive step forward. And really, hopefully, will help us with flow in the long run by developing the standard work.
So I'm going to just say a big thank you to Steph and the medical teams, and also to Jason and the IMT teams who are helping make this happen. So it is brilliant. But on a more ground note, we're also trying to make sure we measure the impact of better decision making, because if we're not careful, we could have the same conversations rather than better conversations. So I know Steph's got that in her sights with the ward team, and then we might talk about rollout. So there's some really lovely comments on here, and I just want to pass on a couple of them before we move on. So firstly, there's a really big thank you and well done from Anne in the comments list. So for everyone on the presentation today and doing the work, really well done. I think Anne's had to join another call, so thank you very much for that, Anne. And I'm trying to pick up, there's some nice comments from Nick Thomas, who says, no whiteboards, fantastic, it's great. And Jason, thanks for your comments there. I'm just trying to catch Di as well. It's a question. Oh, she wants to catch up with you afterwards, so that's great. So that's fantastic. So there's obviously work going on here and on several wards. That's the main updates we've got. We've got a very brief update. Unfortunately, no presenter on ED blood, so I'm just going to do it extraordinarily quickly and let them do their own talking. The team supported ED almost 4 weeks ago to help them with the taking of bloods process, which had quite a variable delay in taking bloods and getting them to the labs. I would say from some brilliant teamwork and using all the tools that I think you would expect a team to use, such as standard work, visual signage, understanding data. Next slide, please. They've taken out 15 minutes of the blood taking process. And as you can see from the lovely middle picture there, also with, thanks to the estate team, a lovely arrangements for pod refills and supply, so that they now have a principle of 1 sample, 1 pod, and it goes directly to the labs. And obviously that also helps patient flow, and ultimately might also help crowding when we combine that with other improvements. And there's still more to come in terms of using blood trolleys and proper electronics, all the full setup that we'd normally do. So I just want to say a big thank you to ED and the team for doing all the work there. I'm not going to take too many questions, but it was really, really nice piece of work. So well done, everybody. Our next little section is just people know we've been working on CAT, and it's one of the few phrases that we stick to that sticks to Japanese. It's our approach to scientific learning and simple storyboards that help people make improvements. 2 people have made big leaps and bounds in the last month. So, and both have presented today. So Kerry, I apologize, I spelled your name wrong as I typed it quickly. Kerry Killeen, the Imaging Improvement Manager, and Laura Goodspeed. Today, somewhere in the post you will receive a certificate, but well done on getting to Purple Belt. And both of them are now encouraging to coach others and improve their coaching technique. And just as a highlight, we're also coaching 20 other people currently in CATA, and that's from topics in STU with rewash, all the way through to work I know it's gone at IMT to improve the help desk. Very straightforward, simple tools, which are now, I think we can see the impact of when people use them effectively and learn to make scientific-based change. That's the main presentation there, and it's the next slide. I would really just like to invite 3 people or maybe 4 people to pass a comment, and apologise that's not everybody, but please throw in questions because we will try and capture them afterwards. I'd first like to maybe go to Alan Martin, the National Director, if you've got a few words.
Guys, that was really good. I've only got one thing to say. I need one of these recordings to send it to every other site on the programme to hear and see what good looks like. It was just so impressive, really. And I need to talk to you, Richard, about how I can be doing my job better, because you and your team have done a great job. So thank you.
That's very complimentary to the whole team here, Alan. So thank you very much. And we'll send you the recording, by the way. I'd just like to go to a person, by the way, who gives us lots of support, including Alan, by the way, but Elaine Mead, who's all the way up in Scotland, who's been listening very quietly in the background. I don't know if, Elaine, you'd like to say a few comments.
Yeah, thanks, Richard. Fantastic work, and it's great to hear so many different teams and departments reporting out today. Every project that we've heard about today's shown improvement, particularly in the experience for patients, reducing either the time wasted or improving the safety, and all of those things are tied straight back to the strategic objectives that Sarah was talking about right at the beginning. So you can see how this is making a huge difference. What I'd ask are 2 things. One is, show me how you know you've made an improvement. So I've seen quite a bit of data over time, but you've got lots more there I can hear when you're describing it. And I'd encourage you to keep collecting that data and be really curious about what that data is showing you. And the other thing is, there are a couple of times when I was hearing that people were absolutely looking at the issue from their own perspective and trying to resolve the issues and the problems that they're experiencing. And I'd encourage you to look at it not just from the experience of a patient and from a perspective of a patient, but maybe from another perspective of, say, the ward. If 2 or 3 of you are drawing up checklists or asking people to do different things on the ward, have a think about what that means from the ward perspective as well. I was really excited, as others were, and I could hear Nick was, about the move to a digital MDT. That really could be a game changer. So again, that will be so different for people thinking about how we're going to change the current practice. All of that's improvement, all of that you're right in the middle of. Absolutely great work, and keep going. Looking forward to seeing it myself when I come down to see you next.
So thank you very much, Elaine. And just back to Alan and Elaine, your support and help to us is keeping us on the straight and narrow, I think, in terms of keeping to those principles. And we will come back on both those points to Elaine when we've got a bit more clarity. So thank you very much for both the comments. I think I'd like to, there's 2 other people I'd just like to make comments. So Nick is also sat there quietly in the background, and I report into Nick. So Nick ought to have something, and then I'll pass over to Sarah, and then I've just got one last slide to do. So Nick, have you got any comments to make?
I haven't got anything deep and insightful, to be honest. Just it was fantastic to hear all of the updates. It's a bit weird doing it virtually and not being able to see people and to smile and to celebrate with them. But it was fantastic to see so much good work. I think it's incredibly refreshing to hear about individuals and teams that have taken on challenges and delivered it and can actually evidence the improvement, which is fantastic. So I really look forward to these sessions, and yeah, well done, everyone.
So thank you, Nick, and I'm with you on the not being able to see people in presence, but I'd also encourage certainly any of the senior people on the call, if they ever want to go and visit these teams and their huddle boards at a physically distance, appropriate physically distant, but they are out there, and I'm sure they'll be very willing to fill in more detail to anybody. So Sarah, you kicked us off. So I think you apart from the last slide, you get the last
Thank
shout.
you.
So how has this been for you?
Thank you. Well, as everybody's just said, just really impressive. And you know, we are a bit camera shy, so you can turn your cameras on and see us. I've got mine on, so it would be good to see some of your faces as we do the next one of these. But yeah, just so impressive. And it really, I'm just sitting here listening to all of that and thinking every single one of those reports tied straight back to our strategic objectives, whether it was around improving patient flow, thinking about how we better utilise our assets, thinking about outpatient clinics, and all of those objectives, of course, have got the underpinning mission about high quality, safe treatment of patients. So just for me, there was that golden thread running through all of those. And the other thing that came out loud and clear was the way that every single team we heard from today has picked up and dealt with the COVID situation, and not just got on with it, but learnt from it. And actually what I heard is an acceleration of the original aims and objectives of your programs being really pushed forward further and faster because of the need to respond to the pandemic, which is just fantastic. So the learning has been so dynamic and so real, and I just think we've gone so much faster than perhaps we would have done in normal times. So that's just a huge credit to all the teams involved. So I just wanted to say, wow, thank you, and look forward to the next one. So back to you, Richard.
All right, so I just want to end, and so thank you very much for those last 4 messages. And I just only want to echo what Sarah said. I mean, obviously we are in really challenging times, so it's great to see teams with the skills and the opportunity to make the improvements they really feel are there, and support them in a better way. So I'm just going to highlight that our next virtual report out, and this is, I think, flowed fairly well, so we will try another virtual one, will be on the 21st of August. Hope people can get it in their diaries. And I'm sure there will be 4 or 5 really great team updates, different than you've seen today, ready for the meeting. So thank you all for joining. The recording will now end, and that's the end of the meeting. And I think we finished on time. So thank you very much, everybody.
Thank you.